Good day, everyone, and welcome to today's webinar entitled How Clinical Interoperability Improves the Healthcare Experience. My name is Mark Haglin, and I'm Editor-in-Chief of Healthcare Innovation. Today's program is sponsored by Infor Healthcare. Before we get started, I have a few housekeeping details to share with you. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag HILivewebinar. Thank you. And now it is my pleasure to welcome our main speaker today. We will actually have several speakers, and our main speaker will be introducing his colleagues. Our main speaker is Jörg Schwartz, who is Senior Director of Healthcare Interoperability at Infor Healthcare. He has more than 25 years of experience in the healthcare industry and in the interoperability space specifically. He had previously worked at GE Healthcare and AGFA Healthcare, designing and implementing solutions for medical image and document exchange and integrated care. Besides healthcare IT, his passion is business intelligence and data analytics, and he teaches business analytics as a distinguished adjunct professor at Golden Gate University's Agino School of Business in San Francisco. Jörg, welcome very much to today's program.
Thank you so much for the kind introduction, Mark, and good to see you again.
It's always great to see you. So what I'm going to do, I'm going to ask Jörg some questions, and he will provide you and our audience with his expertise. And over time, he will bring in his colleagues, and he'll introduce them as he brings them in. So let me begin by asking you, Jörg, what is your expanded definition of clinical interoperability, and why do definitions matter in this case?
Yeah, that's a good question, Mark, because a lot of people, when they hear clinical interoperability, they think about the interoperability between the EMR and the lab systems inside a hospital, or between the traditional providers in the care continuum, let's say the outpatient providers and the post-acute facilities. But when you talk with customers these days, with healthcare professionals, the scope has really widened when you bring in social determinants of health. And now you're suddenly talking about bringing in non-traditional healthcare providers. You're talking about social services, you're talking about transportation providers, you're talking about food providers when you talk about food insecurity. So a cast of characters that are non-traditional healthcare providers. When I had a discussion with care manager, she even mentioned not podiatrists, but the people that do pedicures, because sometimes that is also needed for people that are elderly and don't have a way to do that themselves. So a whole cast of characters, from Uber, transportation, to food supplies, that all need to exchange information if you want to meet all the quality metrics that are nowadays required in value-based care.
That's fascinating. Yeah. Pedicurists, people who do pedicures. Amazing. Yeah. So, no, I love that answer, Jörg. And one of the things that's very obvious is it is a cast of characters now. We, as we share data to improve the health status of individuals and populations, it's not just the pure clinicians inside bricks and mortar patient care organizations. So, Jörg, what do you see as the key challenges to data exchange across all of the different types of provider organizations and providers across the continuum of care?
Yeah, when you talk about this cast of characters, you have really a variety of data types. So on one hand side, you have the traditional providers in hospitals, long-term care facilities, other post-acute facilities. And with those, we have HL7, HL7v2 or CDA to exchange data. And that alone already is problematic because HL7v2 allows a lot of variation. So when you try to aggregate the data or when you try to measure, for example, clinical quality, you have to normalize and cleanse this data. You have to probably use common ontologies for this. And then on top of that, you have these non-traditional healthcare providers. And let's take as an example a social worker. They don't understand, their systems don't understand HL7 or CDA. So now you're talking about completely different standards that are not even healthcare standards. You're talking a lot about natural language processes, text, unstructured data that needs to be exchanged. And if you want to utilize this, one of the ways that people want to use data nowadays is not just the traditional exchange of data that we've done in healthcare for many years, but it's also real-time workflows where you have APIs because people outside of healthcare are used to do everything with their phones and they get access to everything in real time. And that's what people expect in healthcare as well.
Yeah. So it's not just the diversity of people and organizations involved, it's the diversity of data and information involved, correct?
Yes, yeah. Absolutely.
Yeah, I think that's
the way how data needs to be accessed is also very diverse these days.
Exactly. There are a lot of layers. So, Jörg, what are some of the benefits of clinical interoperability for patients and for patient care?
Yeah, building on what we just discussed, I think patients nowadays want the convenience to engage with healthcare providers like it is common in other service interactions today. For example, when I schedule an appointment with my healthcare provider, I still have to pick up the phone and call them because they have a call center. I cannot go to my chart and just make an appointment or shift an appointment. I have to call and ask them and, wait half an hour on the phone and so on and so forth. So that's not what patients want. So patients want to be flexible. They want to have mobile interfaces. They want the information. Service providers, they want to know where they need to go, when they can go. They want to decide when they want to go. And the Cures Act that becomes in effect, or has parts of that, as you know, have already been in effect. Other parts will be coming online. But the info blocking rule is already in effect, and that gives patients the right to access all kinds of healthcare data. Not only access it, but get it in digital format so they could download it and go to another provider if they want to. They can download it and use it any way they want. They could use it for life insurance underwriting. They could use it for clinical trials if that's what they want. Because it's very clear that the government wants patients to be the custodians of their data, and we have to build the infrastructure to support that.
Absolutely. Do you think that provider leaders, meaning the health IT leaders and senior leaders in patient care organizations, are understanding at this point the fullness of the Cures Act's provisions and also everything that's going to happen with TEFCA, that that they are understanding the extent to which healthcare is going to have to be truly data connected?
That's a really good question and really tough to answer. My guess would be I don't think that everybody understands the full extent. I think Mickey Tripathi, who's currently the national coordinator, has a really broad vision. He's been doing this for over 20 years. We know him from all the work that he did in Massachusetts with the eHealth Collaborative. He has a very broad vision for how patients can access and use and interact with healthcare data. And I'm not 100% sure if everybody really understands the broadness of that vision.
Right. I think you're absolutely correct, Jörg. I just wanted to get your sense of that. Mickey Tripathi spoke at Vive a couple of months ago, and he was trying to give the audience a sense of the breadth of what they're hoping to achieve at ONC. But I think it is hard for the average senior leader in a hospital, medical group, or health system to fully grasp where we're going and what it all means. So, for that, what do you see as the benefits of clinical interoperability for providers and clinicians?
Yeah, that's a really good question, because the providers always look at the downsides of new regulations because it's more work. Regulatory compliance always means they have to do something, and change is hard. But let's talk about some of the benefits. And I think, in short, there are two primary axes in which the expanded interoperability can help care providers. One is improving workflows, which also makes their life easier, and also by using more data analytics. If you look at a healthcare and compare it to other industries, I would say that most healthcare providers do a lot less data analytics than a retailer. If you see how retailers, how much effort they put into analyzing data, and you compare that to healthcare providers, we have a long way to go to get to the level of other industries. So I think analytics, and a good example for that are clinical quality parameters, or ECQMs. They have been defined over the last several years to really make clinical quality quantifiable, so that you can, in the value-based care context, say, here I have a population, I give a population to a managed care organization or an accountable care organization, and I want to make sure that the overall health in that population gets better. And how can you quantify that? And that's what ECQMs are for. So you can use the data analytics to assess that, and then see gaps in care, and then address the gaps in care. That's ultimately good for the patients, but it's also good for the providers, because that's how they can unlock their bonus payments. Another analytics opportunity is bring together operational and clinical data. That's something we at Infor work a lot on, because we see a tremendous value when you bring, for example, finance data from the ERP and revenue cycle data from the EMR together, and you can use that. On the revenue cycle side, you have the patient data. On the ERP side, you have cost data, cost center data, etc. And somehow you have to bring that together. There was a really cool article from Kaiser Family News, Kaiser KFF.
Kaiser Family Foundation, yes.
Kaiser Family Foundation. Yeah, about appendectomy. There was a U.S. citizen that got an appendectomy by UPMC, and he lives in Switzerland and had insurance in Switzerland, and it was really interesting because UPMC charged $45,000 for the appendectomy. It turns out that in Switzerland, which is the highest paying country in Europe, the average appendectomy costs about $3,500 in equivalent, so roughly less than a tenth of what UPMC charged. And Switzerland is the most expensive country. Germany is half the cost for an appendectomy. This was a 10-hour outpatient visit. They didn't even hospitalize them for inpatient. So it's a really interesting article by KFF. But if you talk to a hospital about that, first of all, they could look up what they charge for it, and they might charge $7,000, they might charge $15,000, they might charge like UPMC $45,000. But it's really hard for the hospital to assess what does it actually cost them. Does it cost them really $40,000 to provide a 10-hour appendectomy, or does it cost them $2,000? And for a lot of hospitals don't have the answer to that question. So anyways, just as an example, it is very important for hospitals down the road to understand what really their costs are for certain procedures. And that's hard for them to do right now because the cost lives in one system and the care lives in another system. So you have to bring the data together and analyze it. We call that activity-based costing. And then finally, modern workflows that integrate APIs that are healthcare specific and not healthcare specific, and allow you to create very flexible workflows could be also a tremendous benefit for healthcare organizations because they don't have to build everything statically like the old-fashioned way by buying an application or programming an application, but by just stitching together a workflow from commonly available APIs. So there could be a lot of benefits for the providers as well if they use the expanded view of interoperability.
That was a wonderful explanation, Jörg, and I completely agree. One of the challenges now as we move towards federal government mandated pricing transparency is that hospitals and health systems don't understand their costs. It's very hard to explain to international people who aren't from the United States how that could be, that hospital systems and health systems would understand their charges and not their costs. But it's that kind of disconnect is endemic to our system, right? I'm sure you have some.
It's hard to explain. I think it's even hard to explain to people here in the US that are not from the healthcare industry. Right. That they charge something and they don't fully understand what their actual cost is.
Yeah, it's amazing. So I have talked to consultants who say until recently, when they started getting into value-based payment and value-based contracting, many CFOs of many hospitals couldn't tell you what a CABG, coronary artery bypass graft, actually cost in their system. Kind of astonishing. Yeah. So
not even something as simple as an appendectomy, which you would think is a lot easier than a CABG.
Right. But the processes are so disconnected and siloed with their data. So great points, Jörg. So you referenced clinical workflows. Tell us, does it require rip and replace of existing infrastructures in order to achieve true interoperability in terms of workflows?
Yeah, that's one of the key points I wanted to make today, actually, is that with the modern way how we interpret interoperability, a rip and replace is not required. We just announced that HIMSS, the i4 solution, Infor Fire on-ramp, and with that we can enable modern APIs on top of existing legacy infrastructure. So the existing legacy infrastructure doesn't have to understand APIs and it doesn't have to understand what is required for those APIs, but we can put this on top of the legacy infrastructure. And that is really important these days. As you know, Mark, all the hospitals that we talk to cannot afford a rip and replace. Right now, the financial situation is very strained. So on one hand side, they have a lot of demands from the government, from other stakeholders, from their own stakeholders inside the hospital for modern workflows. On the other hand, they cannot afford to rip and replace their existing system. So it's very important that you use interoperability to fill that gap and build an interoperability infrastructure on top of the legacy that supports modern workflows and APIs.
Absolutely. So I know you're going to begin introducing us to other colleagues here, but would you like to share an example of one of the workflows that you would be talking about?
Yeah, absolutely. I think it will help everybody if we go into a couple of examples. And for that, I invited my colleague, Chad Yerger, here. Chad is one of our solution consultants. So he works day in, day out with a lot of our customers. And he is deep into doing what we are talking about every day. So Chad, why don't you show us a couple of examples how we can use existing legacy infrastructure and enable modern API workflows on top of that?
Yeah, thanks, Jorg. Yeah, I have a short video here to show how we can achieve these modern workflows, like how to enable the digital front door to build workflows to query from and post to FHIR-enabled resources, and also how we can use Cloverleaf to be the event driver for that legacy data and drive complex API-driven workflows as well. So let's get started. All right, hello everybody. This video is to demonstrate how we can build clinical workflows, but also allow for those clinical workflows to have user interaction. So these are automated workflows that will allow us to bring user decisions into critical points of the process. This specific workflow is around patient scheduling. So in some cases, patient scheduling may request a specialty or a specialist with no designated physician, and we can get eyes on these requests and let admins assign the correct available physician and let the automated processes continue. So we'll look at this workflow with two different perspectives, one in which a web portal or a mobile app, say the digital front door, is allowing the patient to request. And the other way is the request hits the EMR, EHR through the scheduling system, and Cloverleaf interacts with that data. All right. Okay. So looking at this model here, which is all drag and drop, low code, no code, built on our API gateway, we just chain both API calls and user notifications and user decision points to build a complete clinical workflow with interaction. Let's look at this little start bubble. Specifically, the input parameters are what I expect coming into the workflow. So things like appointment end and appointment start date, the patient's cell phone, the patient's first name, physician, and there might be more parameters that we might expect in a production environment. We're just testing this out, okay? Here we have a decision flow, right? So we are actually going to get eyes on the data coming in through this request receive. Basically, we do this through actions and distribution, right? So we can get users involved in this. If that user approves the data coming in, and again, they can even change that data coming in, it will follow through to the yes branch of the workflow, where we get to this first API. This actually hits our FHIR bridge and calls this post an appointment to schedule the appointment. We'll send a notification to the actual administrator of the workflow that this was scheduled. We're going to actually convert the date that came in. If you remember, the start date comes in as the HL7 date structure. So we want to make that a more readable format. This is the only place where I added code, by the way. We can incorporate Python in one line of code, right, to convert that date. Here we actually massage the body of the text message that's going to get sent out. And then we call the Twilio API to actually send out the SMS message to the patient. So let's take a look at how we can mimic this in the API gateway. We have something called our homepage area where we can add widgets, and those widgets can actually mimic workflows. So let's go ahead and get a workflow started. We'll actually click on this plus sign, click appointment request. And again, we've got some sample parameters coming in. I just really wanted to know the date structure, so I'm gonna just change this to, okay. So I set an appointment start date for the 1st of December for 8 o'clock through 9 o'clock. Let's put the patient's cell phone in here. We'll put my cell phone. I'm not going to set a physician. We'll choose a physician. We'll just set it in a group. All right, now at this point I can choose start. This will actually send these parameters into that workflow and get that workflow started. All right, to see the status of that workflow, what I can do is I can show this workflow in the workflow viewer down here, this widget. All right, so I can see that it's on this first step. I'll go into my inbox, right? And notice I've got this new appointment request. Right. So again, this is where that user interaction comes into play. We've hit a point in that workflow where we want somebody to get eyes on that critical decision-making process. Let's click on the new appointment process. Because this is part of a group of users, I'm going to assign it to a specific user myself. I'll assign it to me. This is where I can get eyes on that data and change that data if I need to. All right. So again, we've hit a critical decision point in the process where we need to assign that physician. Once I do that and confirm, it's going to continue on to the other pieces of the workflow. Here, we'll go back to our home pages. What I'll do is in my workflow viewer, I'll refresh this. Okay, I don't know if you just heard that, but I got my text message that just came in. So we can see that this has gone through each step of the workflow and sent out the SMS text message to my phone. So this completes the demonstration from the perspective that this information has come in from either some type of web portal or some type of application. All right, so the next would be, let's see what happens if this comes in through the EHR EMR and we get Cloverleaf involved. So getting Cloverleaf involved. So what I've done is just build a simple interface, right? So we've got basically a raw client here that connects to the workflow API in the Cloverleaf API gateway. We can take a look at the properties of this. Really, it just calls the workflow start API. We just have to send in parameters like the workflow name and then whatever requires for those input parameters. And we do that through, of course, the routing and going through the translate. So in translation in Cloverleaf, then we just take that HL7 message, we grab the key parts out of it. We're assigning that to the workflow parameters, right? We do assign the instance name, right? That appointment request. And then those other input variables like the appointment start date, the end date, if we're sending in a physician, the patient name, cell phone, things of that nature. And then to do this, right, we just go into our network monitor. We start up that interface, and what I can do is I can just drag and drop a file in there. We're acting like we're receiving messages across the network. Right, so I built this SIU25. Again, this is simulating a message coming across TCP IP. And again, notice we've got a designated physician already in here. We got Dr. Bryce Harper. This is an appointment for this time, December 2nd at 9 o'clock through 10 o'clock. And again, in the cardiology specialty. All right, let's go ahead and drop this in. Here's a sample SIU message here. We're going to drop that into this chat folder to get it picked up. All right, let's wait for that to be gone. All right, so it got picked up. Let's go check out the logs. All right, look at that. So that SIU message got sent across into the Cloverleaf API gateway. That workflow got called, it got started, right? There's the appointment request. There's the data, the parameters, the input parameters that got sent over. There's Dr. Bryce Harper, the cardiologist, patient information, and we got a response code of 200. So everything went well. Let's go back over to the Cloverleaf API gateway. All right, let's go back to my inbox. Notice again, I've got that new appointment request. Let's check out the data. There's the data that came across from Cloverleaf. There's Dr. Bryce Harper. Let's assign this to me. I'm good with all of this data. I don't need to assign a physician at this point since he's already in there, and I'm good with that. I'll confirm. Let's see if we can hear this one. There it goes. There's my text message that just came in. So I can also look at this message and validate that it is in our Fire server. In my appointment history, I've got a lot of appointments in here. We can just do a quick search by maybe Harper. And there we go. We've now confirmed that that workflow actually put that appointment request into our Fire server. All right, so that concludes today's demonstration of how we can utilize the API gateway to automate clinical workflows, but also automate them in a fashion where we can get user interaction involved.
Thank you, Chad.
All right, so just to follow up on this, a few additional use cases around scheduling and telehealth. Jorg already talked about this, the ability to add maybe Uber Health APIs to coordinate ride scheduling to and from appointments. Of course, if you're also including telehealth, set up video conferencing links via those APIs, so, such as Teams, Zoom, whatever video conferencing platform you're using, and send those to the patient and physician. Get patient e-consent, right, or e-signatures, things like DocuSign, right, so you can get the patient consent for those telehealth or any type of visit. Use the patient demographics and the diagnosis lookups using FHIR, right, and find possible clinical trials post-appointment. And then also call out to insurance for pre-auth. There's APIs for that, and using patient queries via FHIR to do that. So hopefully this segment offered a few useful ideas, and I'm going to go ahead and pass it back to Jorg and Mark. Thank you guys very much.
Thank you, Chad.
So much, Chad. Yeah. Would you like to say anything about what Chad just presented?
Yeah, no, in summary, that was an example how we can build on top of an existing infrastructure in no-code or low-code ways, workflows. And that's what I said earlier is really an advantage for providers because they don't have to rip and replace their existing infrastructure. They can build these modern features like notifying patients, giving patients web access on top of their existing infrastructure.
Wonderful. Thank you so much, both of you. So, what about the analytics use case? Why don't you share with our audience thoughts about that?
Yeah, absolutely. And when it comes to analytics, a picture is always worth more than 1,000 words. So that's why I invited here two colleagues, Dr. Shahram Shahpouri. He's a medical doctor and he's our principal healthcare data architect. And then a dear colleague from a partner company, Diet, Dr. Stephen Hamblin. They're both Canadian, by the way. So kind of interesting that we are talking about a value-based use case here in the US, and we have two Canadian guests to explain this to us. But what matters here is they tell us how we harvest the data, again, standard data formats, and turn this into clinical analytics. So I hand it over to you, Shahram and Steve.
Great. Thank you very much, Jorg. Just a quick intro, as Jorg mentioned. I'm the principal healthcare data architect in Cloverleaf. I'm a medical doctor, and my area of expertise is mainly around the healthcare messages and interop and then terminologies and data quality. And so I'm based in Vancouver, Canada. With me today is Stephen Hambling from Diet. Stephen?
Hi there. Yes, I'm from Diet, which it's even worse than Jorg said. Not only am I Canadian, but I actually live in the UK. So, but my background and our company, we work in building software and AI solutions based around semantic AI, which includes knowledge graphing, graph-based machine learning, and clinical NLP. And those are the things that we've been bringing to this project that we're really excited to be working on with Infor.
Great. Thank you, Stephen. So if we can go to the next slide. So as Jorg mentioned, today we're talking about the expanded role of interoperability. And you know that we have systems currently that can send standard healthcare messages from system A to system B easily with no problem. and we have the data, we have the systems, we have the data scientists. But when it goes to the non-healthcare or less healthcare related systems, it would be very challenging. So in different areas. So one of the areas that is one of the biggest obstacles is about the content that we are passing between the systems, like how we can match the patients in this workflow that Chad presented, and what about the wording differences, terminologies, and then code normalizations, the mappings. Each system is different, especially when you think about that. We are not talking about hospitals only or healthcare facilities only. We are thinking about an expanded role, something like we are thinking about social determinants of health. We are clinics with different systems or different purposes. And then aside from the content, it goes to syntactics. So not all the systems are talking in the same language. So yes, if everything is a standard HL7 or CCDA, yeah, that would be easier. But we are talking about different formats, comma-separated files, databases, scattered. And as Jörg mentioned, we are not thinking about a rip and replace and say that, oh, okay, so if your system is like that, you have to replace it. Here, Cloverleaf can handle these parts of the solution. Like, we can enrich the content, we can convert the format and structure, the syntax to a standard format, like the Infor solution that Jörg mentioned before. And then it goes to the semantic layer, which I handed over later to Steven to talk about. But at the end of all of those workflows, even in the analytics, we need a feedback of the data back to our systems, like how we can feed it back to the patient or to the EMRs or aggregate for analytics, notifications like what Chad showed, and even other formats like, wow, we want to convert everything to OMOP, to QRDA, to HADIS measures, whatever. All of these things. So Cloverleaf does the interoperability part in the content and syntactical areas and communication workflow. And now I hand it over to Steven to show you how Dyad can fill the gap in the semantic layer and AI so that we will have a full solution. Steven, can you please walk us through?
Of course. Thanks, Rob. Yes, I mean, to kind of hammer on that point, you know, one of the things that's so lovely about working with Infor and the Cloverleaf product that they have out is, as Sharon was talking about, that interoperability layer, which is done for us, because as much as I love to build data engineering teams, you know, there's only so many hours in a day, and they've done a beautiful job of bringing that data into a normalized format, you know, in good FHIR structure, you know, in a way that can be used and remixed in higher level applications. At Dyad, we focus on what we talk about as semantic interoperability, making sure that when data moves from point A to point B, that when it arrives, it means the same thing as when it left, right? So, you know, a simple example would be like, what is the definition of, you know, say, diabetes in a hospital or primary care setting? It might be, you know, a wide range of conditions, whereas in, say, a clinical trial, you know, it's going to be very specific because it needs to be. And we focus on that layer, making sure that, you know, the data means what it's supposed to. And when you expose that further in terms of analytics, you have confidence and trust in what you're building because you know that, and you can prove even, in some cases mathematically, that this is the case. And so we've built a solution in partnership with Infor, which we're really excited about, and we're bringing out together around, as Jörg mentioned, ECQM. And so the architecture of this is actually based on a set of interlocking capabilities and services, which start with you know, a wide range of input data, which is brought in through Cloverleaf, and, you know, as Shram said, normalized, cleaned up, gotten into the right condition, and, you know, we'll store it in a component like AWS Health Lake in order to, you know, provide a secure, safe storage for it. And then we work with a series of machine learning tools on top, which, as I said, we focus on knowledge graphing and graph-based machine learning. So we work with tools like Neptune and our own in-house technologies. And then on top of that, we can layer on additional exploratory data capabilities through things like AWS SageMaker and our own, you know, like we can do graph ML embeddings on top of that. and then finally expose that to an end user to make it concrete, because transforming data is nice, but unless it actually helps somebody in the end, you didn't really do your job. And so we expose it through dashboards and other kind of low-code explorations to people like population health managers and other interested stakeholders and parties. So in terms of the specific capability we're building for ECQM, we've been developing this and are presenting this to the end user stakeholders in terms of a nice set of analytics in which they can drill down into what their achievement is on the various measures, because this is a very important reporting measure to CMS for them. And they can split the data in whatever way they like. And underlying all of this is a rigorous expression of the rules of the ECQM setup, which, I mean, I don't wish it upon you, but if you've ever gone and read the actual PDFs and everything involved, it's quite lengthy and quite involved. We've turned that into a knowledge graph upon which we can do logical inference, and that powers an analytic solution like this. Yeah.
All right. Thank you, Steve. So this is really an example, and let me summarize this, where we take the data from multiple different data sources, because that is required when you really manage a population. One of the examples I always use is ECQM 112 or HEDIS measure 112. It's diabetic retinopathy consultation. So once a year, a diabetic patient needs to get their eyes checked for retinopathy, and you have to refer to a licensed physician for that, so for an ophthalmologist. And so there's an interoperability component. We have to collect that data from the ophthalmologist. We have to put it into this data analytics, because we want to show that, yes, this patient has gotten their mandatory eye exam. So we get that quality measure checked off, and it shows in the continuum of care, you have to collect and normalize the data that comes from many different sources. So thank you again, Steve and Sharam. Mark, was that a good way to show what we mean with clinical analytics?
Yes, absolutely. I think it was brilliant, and very, very interesting too. Showing is better than telling. And that was a good example of how that actually works. So wonderful. Thank you so much, Jörg. And finally, tell us about the concept of pre-packaged interoperability solutions and how customers benefit from them.
Yeah, absolutely. So that's one of the things that we're working on here at Infor, because traditionally interoperability was a little bit of a construction set, right? Where, I mean, I've been doing it since 1995, and interoperability was always, we sell you the different components, and then the customers have expert teams that build them together and build the different interoperability. We have some customers that build hundreds and hundreds of interfaces to transact millions of messages every day. So that's the traditional way, and we will keep doing this. And I would call that the a la carte approach, where the customers can buy from us what they need. But we talked about the expanded role of clinical interoperability, and that reaches new user groups. You have to include people that don't have the power, that don't have the teams for interoperability. That could be startup companies. There's now, for example, provider startups that provide diabetic retinopathy scans as a service, and they use telemedicine capabilities. The primary care physician takes a picture of the retina, sends it to an ophthalmologist, they do the reading, and they send the result back so that the patient actually can get the diabetic retinopathy scan while they're at the regular health visit. We can support all this, but in these cases, not everybody has all the tools and the teams to do that. So that's why we developed some packages that are pre-configured. I4 is one of those examples where We take the data that is in different formats. We normalize it, as Steve and Sharam explained. We load it into a data lake, into AWS Health Lake, for example, and then it can be analyzed in the solution that they showed for clinical analytics. So there's a prepackaged solution that is offered as a fully hosted cloud service, as a SaaS, as they say, software as a service. So you don't have to buy all the components separately, but you can get the solution out of the box. And the starter pack that we offer on the AWS public marketplace starts at $55,200, so only $5,500 roughly per connection. So it's very affordable. Small organizations can afford this. The I4 package starts at $99,500. Again, very affordable, up to 20 million FHIR resources. So very affordable, fully managed, comes with a professional services package. So the advantage for providers is that they can tip their toe into doing data analytics or building the workflows that Chet was talking about by using these pre-packaged solutions at a very low cost, very low risk, without having to have an expert team. And then if they like what they get, of course, they can expand it. So that's a new approach with which we want to reach those new customers in the expanded scope of clinical interoperability.
Wonderful. Thank you so much, Jörg. Let me ask you one question, and then we do have an audience question. But to kind of summarize where we're at now on this interoperability journey, what does the next few years look like to you around all the subjects we've discussed?
Yeah, I think we will see today, for example, the pickup of FHIR is pretty minimal. 99% of transactions in healthcare are going on with HL7 v2, which is a 30-year-old standard. So we will see that will change. There will be more and more use cases, workflows, analytics. One of the Cures Act things that is coming up is the burden reduction workflow between payers and providers that requires FHIR. So we will see more an adoption of FHIR, but what's really important is it's not technology for the technology's sake, but it is really allowing us to expand how we use technology to improve patient experience and to also improve the business and operational experience of providers.
Wonderful. Great summary. Thank you. Thank you so much. We do have one audience question, so I'll ask it to you and ask you it, and then you and any of your colleagues can respond. The audience member's question is thus: in Europe, we are focused on projects like European Health Data Space, and in Germany especially, Patient Data Protection Act, to shift towards electronic patient files. Can we expect a collaborative approach to this with TEFCA here in the US?
Oh, that's a very interesting question. The honest answer is I don't know. Germany specifically and Europe is a little bit behind. Some European countries have good healthcare interoperability, other European countries not. The landscape in Europe is very varied. Germany is definitely behind in data exchange. I think 95% of data in Germany is still transferred through faxes. I mean, there's still a lot of fax transfer here in the US as well. Let's be honest about this, but definitely to a much smaller extent than in Germany. TEFCA is a great approach, and Trusted Exchange Framework Common Agreement. Two very important parts. One is the Trusted Exchange Framework. So you have to create an environment where you have a a secure exchange of data, and that is based on the common agreement. It would be fantastic if Germany creates a similar regulatory framework, and then the technology. I know that in Germany, for example, and in Europe, they already leapfrog and they're already adopting FHIR very much. So FHIR is definitely one of the enabling technologies. So on the technology side, I'm not concerned. I think Europe and specifically Germany can catch up to the US here. What's important is A, the regulatory framework, similar to TEFCA, and B, also an organizational framework. There have to be organizations that can be the trusted exchange framework organization.
Absolutely. And if I may, Jörg, I'll add one
please.
Policy note. Thank you. Well, Germany and France are strange because they actually have regulation imposed walls between inpatient and outpatient care. That, to me, they're going to have to, both governments are going to have to do something about that, because technically in the German and French healthcare systems, they're actually not supposed to share information between inpatient and outpatient. I know they're trying to do something about that, but that it's actually a system-wide stumbling block.
Yeah, they're not supposed to integrate. They want to keep it. There is data exchange today. There is data exchange through faxes, which it always puzzles me that some people think faxes are secure. Have you ever gone into an office and you see the fax machine and there's faxes lying around? Nobody does access control on a fax. I don't know why data security experts think that faxes are fine, and it's fine for an outpatient provider to send a fax to a hospital, but not electronic information. That
I know it's
just
kind of
boggles
crazy.
your mind.
And as you know, I'm sure in any busy clinic or hospital, the fax machine is sitting there and faxes are falling to the floor.
Exactly.
There's like no physical organization.
No.
So someone could literally walk by and grab one and no one would know.
Absolutely, 100%. There's zero access control, zero data retention policy, et cetera, et cetera. And that is considered to be the safe alternative. So yeah, I don't know.
Yeah.
We definitely need to get rid of faxes.
Yes.
Here in the US as well, but faxes are incredibly unsafe, and we should be all ashamed that they still have to be used in healthcare in 2023.
And backward, they're unsafe and backward. My gosh, they're.
I know. Can you imagine any other industry? Can you imagine?
No.
Let's say, for example, Mark, you want to order something from Amazon. You call them and you ask them if you can send them a fax with your order. Right. I think they would fall off the chair laughing.
Yes, the young person at the other end of the line would ask me what a fax was. So.
Yeah, probably. Yes.
So this has been wonderful, Jörg. Just summarize for us, if you don't mind, what we've learned today, and then we'll conclude. What would you like our audience to walk away with?
Okay, so interoperability nowadays is more than the interoperability that we know from 20 years ago. It has an expanded view that includes the entire care continuum, including non-traditional healthcare providers. That's number one. Number two is we can create communication and infrastructure with this expanded view of interoperability. Without rip and replace, we can build workflows, including modern APIs, and we can include analytics with a variety of data by cleaning up the data, by using standard APIs for the workflows. This is all possible without rip and replace. We showed how we do this both for workflows, and we showed an example to do this in analytics. And we have even built pre-packaged solutions that help organizations to tip their toe into these type of modern interpretations of expanded healthcare interoperability with those prepackaged solutions that are fully managed and very affordable.
Wonderful. So thank you so much.
Oops, I think we lost Mark.
Okay, I'm back. Did you lose me just now?
Yes.
Yeah, okay.
Yeah, we lost you. But I think you were just wrapping up the call.
Right, I was just thanking you. So I want to thank you, Jörg, and I want to thank Stephen Hamblin, Shahram Shapuri, and Chad Yerger for helping us also in this webinar. Sorry, I disappeared for a second there. I don't know what happened. But thank you so much, Jörg, and to all your colleagues for your wonderful expertise today. That is all the time we have for today. Thank you again, and thank you, you and your team, and thank you to Infor for making today's program possible. So finally, I want to thank you, everyone in our audience, for joining us. We hope you'll join us again in the future for another healthcare innovation webinar. This concludes today's presentation. Thank you, everyone, and have a wonderful day.
Thank you so much. Wonderful conversation. Thank you, Mark.